trying to emphasize some integrated care concepts and talking about stepped care for ADHD. So the objectives I hope to highlight, we're going to review the prevalence of ADHD. I know Dr. Messamore gave a talk on ADHD about a month ago, and he went over some of the prevalence and some of the controversies behind it. I'm also going to highlight the treatment guidelines and discuss some of the pharmacologic treatment of ADHD. So as far as the prevalence, it depends on where you look. In the DSM-5, it reports 5% of children have ADHD. However, when you're looking at parent reports, that percentage can go up to almost 10%. In 2016, 9.4% of children were reported to have been diagnosed with ADHD. And the other thing I wanted to highlight, ADHD commonly occurs, it has common comorbidities with it. So over half of the patients that you see with ADHD are going to have something co-occurring with it, whether it be a behavioral problem like ODD, anxiety, depression, if they're on the spectrum, autism spectrum, Tourette's, among other things. So I think that's very important to be aware of, that a lot of times when you're seeing somebody with ADHD, you want to make sure you do a thorough assessment and see if you can figure out if there's other things going on as well. So as far as the recommendations for the treatment of ADHD, the American Academy of Pediatric has different recommendations based on age. So for those younger than 6, behavior therapy is the first line. And for 6 years or older, they recommend both. I still think the emphasis is to start with behavioral therapy, and if there's no improvement in a period of time, then introduce medications. But it also depends on the severity, and I'll go over a little algorithm in a minute here. One study that I like to highlight for ADHD, it's called the MTA study. It was done at the NIMH. Over 500 children ages 7 to 9 were randomly assigned to 4 treatment arms. One treatment arm was medication alone. The second one was behavior treatment alone. Third one was combination treatment. And the last one was just routine treatment as usual in the community. So as you know, when I talked about the depression and anxiety, combination treatment is always the most effective. So the interesting thing about this is when they looked at if the child had comorbidities with ADHD, combined treatment was better. However, it was interesting to me to see if there was no comorbidities and it was just pure ADHD, the medication alone was superior than both behavior therapy or combination. So it's not endorsed by any organization, but I thought it could be helpful, especially in primary care. It was published in 2014 in the Journal of Psychiatric Practice, and it's hard to read, but it goes over the severity, if it's mild, if it's moderate, if it's severe, and I highlighted it a little bit bigger here. So for their mild impairment, they recommended starting with watchful waiting, and they described that as not doing anything. Somebody at the practice should be following up with the parents, preferably on a weekly basis, just doing a phone call, checking in, and also recommending some books, bibliotherapy. One of the ones recommended in that article was The Incredible Years, which you can get that anywhere on Amazon or the library. And if in a couple months, if there's no improvement or if there's worsening, then they would recommend more intensive treatment. For moderate impairment, they recommend the parents actually attend some sort of parent training. The Incredible Years program actually does have parent trainings. If you go to their website and look up in Ohio, 3 places came up. There was one in Akron, one in Canton, and another one in Youngstown. So you could refer them to the Incredible Years program. Other places that are frequently used are like the Triple P program. Akron Children's has one, as well as my workplace at Children's Advantage just recently started a Triple P program. And various options in the community. If there's nothing close to you, you could, Triple P also has like an online program too that the parents could do. With severe impairment, the article had recommended psychiatric referral for further assessment and treatment. So just to briefly highlight the components in the book, The Incredible Years. So it focuses on, you can see the foundation of that pyramid is focusing on increasing positive interactions with your child. I think that's the basis of almost all behavior management programs, is taking time to play with them, give them 10 to 15 minutes a day of special time where they're leading the play, and it's a positive interaction. Having the parents, a lot of times parents come in and they're so frustrated and it's really created a really negative dynamic with their child. So trying to change the focus, instead of an emphasis on negative reinforcement, emphasize that positive reinforcement has greater long-term outcomes. So just trying to shift the whole dynamic to a more positive nature, and also, setting limits, consistency, and instill consequences for aggression and other significant behavior issues. So I wasn't going to go into further detail as far as the behavioral management program, but I was going to highlight some of the medications options as well. I try to target this more towards primary care. So there's two types of stimulants. There's the methylphenidate type and then amphetamine type. And there's also some non-stimulants that are FDA approved for ADHD, including the alpha agonist medications and atomoxetine, which is a selective norepinephrine reuptake inhibitor. So as far as the stimulants, so their mechanism of action is they increase dopamine in the synapses by inhibiting dopamine reuptake. The amphetamine class is thought to also have be a little bit more potent because it also increases release of dopamine from the presynaptic vesicles. Stimulants, when it comes to pharmacology, so stimulants are considered the first line treatment over the other medications that are FDA approved, unless there's a contraindication. So you always want to make sure you get a thorough personal and family cardiac history. This was a table from a Journal of Family Practice published in 2014. So as far as personal history, you want to make sure that they haven't had any seizures, unexplained fainting, exercise-related symptoms, chest pain, palpitations, fatigue, high blood pressure, rheumatic fever, family history. Ask about if there's any history of sudden death in the family, especially of anybody younger than 40 years old. If there's any heart problems that run in the family, syncope, irregular heart rate, and then also evaluating for any syndromes. So, I usually try to have a low threshold if anything is reported in the family. I do usually, so I tend to refer to cardiology, and so they do the EKG and evaluate it, and we'll give medical clearance. But based on that, not everybody needs. So it depends on who you ask. The American Academy of Child and Adolescent Psychiatrists does not recommend that everybody routinely get an EKG prior to prescribing if there's no clear personal or family cardiac history. Although I believe the American Heart Association actually has an opposite recommendation. So I do follow the ACAP guidelines, but I know there's some other practitioners out there who actually just routinely get EKGs on everybody. As far as stimulants, out of all of the psychiatric meds, they have one of the best responses. About 70% of patients will respond to the first stimulant used, and that doesn't use switching to a second one has a high response rate. There's no general guideline that one medication is better than the other. The overall recommendation is kind of based on age. We know there's more research in the preschool age, like 4 to 6 years old, regarding the methylphenidate products. And sometimes it's helpful to ask if a family member who has ADHD has responded to a certain medication that can give you some guidance as to what to start. But so trying one in one class, if that's not effective, then possibly trying one in the other class, like the methylphenidate or amphetamine class. This is on the Carlett Child Report. I know you can't read it, but it's very helpful. It lists all the, and this is a little bit dated because there's new ones that have FDA approval recently, but it's helpful, I think, to have, and especially for primary care. So I think for primary care, it's not, you don't need to know everything, but maybe knowing one or two in each class. One of the most common, well-known methylphenidate, short-acting Ritalin. So it's composed of a mixture of D-methylphenidate and L-methylphenidate. The D form is considered the more active form. This one, so what's interesting, it actually has FDA approval for ages 6 and older, whereas the amphetamine has FDA approval for younger than that. I believe it's like 3 or 4 and older. However, the American Academy of Pediatrics recommends the methylphenidate be used for the preschool age, so 4 to 5 years, even though it's not FDA approved, because it has more research behind it and more evidence to support its safety and efficacy. Has one of the quickest onsets of actions within 30 minutes, and it lasts about 3 to 5 hours. So typically when you're doing a short acting, it's dosed 2 to 3 times a day. Another short acting in the methylphenidate class is Focalin. It's composed of the D enantiomer of Ritalin, so it's considered like twice as potent as Ritalin, and it's FDA approved for 6 and older. So highlighting some of the longer acting ones, methylphenidate extended release, also known as Concerta. So it is it's an osmotic-release oral system, so it has a little release during the day, and then a slow release, a little burst in the morning, and then a slow release during the day. It lasts about 10 to 16 hours. Usually when you're doing a long-acting, which I tend to actually, unless they're really young and I want to do like a test dose, I'll do a short-acting, but for most patients I do tend to start with a long-acting. The long-acting shouldn't be given after noon because they could potentially interfere with sleep. The long-acting Focalin, it's composed of 50% immediate release beads and 50% of delayed release beads, so it's supposed to mimic twice-a-day dosing. So those, I think as a family practice doctor, knowing those in the methylphenidate class can be really useful as like your go-tos, or whatever you become comfortable with too. Moving to the amphetamine class, so reviewing the short-acting one. So the Adderall has the FDA approval for the younger age group, although, like I said before, the American Academy of Peds recommends use of the methylphenidate for the younger age group. It takes a little longer for the onset of action. The methylphenidate was 30 minutes, and this is 60 minutes, but it lasts a little bit longer, so 4 to 8 hours. So if you're using this one, sometimes it requires twice-a-day dosing. The extended release is supposed to mimic twice-a-day dosing of the short-acting, so the duration is just double at 8 to 12 hours. And then another one that I feel like I use pretty commonly as well is Lisdexamfetamine, or also known as Vyvanse. So it's approved for ages 6 and older. One of the things interesting about it is it's a prodrug. It doesn't get activated until it reaches a GI enzyme, which cleaves off the lysine to make it active. Because of that, it's considered having, like, out of the stimulants, a lower abuse potential, and its duration of action is 8 to 12 hours. So as far as the side effects, I always kind of emphasize appetite suppression is very common. So that weight, height will need monitored. It's good to keep a growth chart to make sure that the child is gaining weight appropriately and growing appropriately. There has been a long-term study that showed that long-term use of stimulants could potentially reduce height in children by a few centimeters. So I do usually try to educate the families about that. And I also will, if there is appetite suppression, figuring out ways to increase nutrition, increase calories, working with the child. They might need to change some of their eating routines to when the child's hunger is back. I try to encourage families to give bedtime snacks, make sure that they have a good breakfast in the morning when their appetite is better. And sometimes we'll also do what's called a weekend holiday, or even depending on what they're doing over the summer, if they're not doing any sort of program or camp or schooling or anything, sometimes we'll go off medications over the summer too. I know Dr. Messamore talked about the risk of psychosis with stimulants, which is, he reported, even more common than reported in studies. And I think I might have mentioned this a few weeks ago. I mean, I vividly remember when I was working in the ER at UH, there was a 4 or 5 year old had just started on Ritalin and came in and was actively hallucinating, feeling like she had the little pillow pet with her and felt like seeing arms come out of it. So it's definitely something to let parents know that, if that happens, go to the ER assessment. The other thing, there's a little controversy over whether it can make tics worse. I know a meta-analysis showed it wasn't significantly worse. So if I do have somebody with Tourette's or a tic disorder, I will just educate them that there's the possibility, but overall, if the ADHD is severe, we still tend to treat the ADHD. And the methylphenidate products seem to have a less risk of exacerbating tic disorders than the amphetamine products. And just to quickly highlight, I know I'm going over, but so the non-stimulants that are FDA approved, the alpha agonist medications, the guanfacine, Intuitive is FDA approved, the short-acting is not, but we still use it off-label. And then as far as the clonidine, the Capve, which is the long-acting, is FDA approved, and the short-acting is not FDA approved, but we also still use it pretty frequently in child psychiatry. And then the SNRI, atomoxetine. So guanfacine, the Intuitive has FDA approval for 6 years or older as monotherapy used by itself or in combination with a stimulant medication. In studies, it shows that you could make a target dosage based on weight, because it seems like those who had improvements started at the 0.05 to 0.08 up to 0.12. So sometimes if you're not seeing improvements with the Intuitive, do a calculation based on the patient's weight to see kind of what maybe their target dose should be. Common side effects, sedation is pretty common. That does tend to go away if they're on it for at least a couple of weeks to a month at a time. Dizziness, it does. The alpha agonist medications can affect blood pressure, so blood pressure needs to be monitored. And one thing I try to educate families too is when you stop the medication, you don't want to stop it cold turkey. You want to taper it down over the course of 3 to 7 days. I would lower it by 1 milligram at a time just to prevent what's called rebound high blood pressure, hypertension. Clonidine, also an alpha agonist. The Capve, the long-acting, has FDA approval for 6 years and older, also can have blood pressure effects, so that needs to be monitored and educated. Families need to be educated to not stop the medication abruptly. And the last one, just wanted to mention atomoxetine. So it works on norepinephrine. Even though it's considered an antidepressant, it was shown to be ineffective for the treatment of depression in children. There has been some studies that show that it may be beneficial in kids with ADHD and anxiety. So sometimes if I'm seeing those comorbidities together, I will start atomoxetine. And it is also it's weight-based dosing, as you can see there. Unlike the stimulants, which you see response fairly soon, these, like all antidepressants, take a while to have a therapeutic effect. Try to educate the families. It takes about 2 to 4 weeks. Side effects, GI side effects. It's less appetite suppression than stimulants, but it's still a possibility. There's a risk of liver injury, and because it's an antidepressant, it also has that FDA black box warning regarding the risk of suicidal ideations as well. And then my last slide just is the Vanderbilt form. I use this very frequently. There's a teacher form and there's a parent form. So I'm frequently getting teacher feedback and seeing if they're noticing any improvement with any new medications or medication adjustments. And also I use this frequently to get collateral information from the school. So that's the talk.